Examination of the thyroid gland. Today we will be demonstrating examination of the thyroid gland. This examination should be performed in a warm, well-lit room. The patient should be adequately exposed. The examiner first introduces himself to the patient and requests permission to perform the examination. Thyroid examination usually assesses the functional state of the, hence one should examine the state of the whole patient, the hands, the eyes, the neck, and end with the thyroid gland. The examination progresses in the sequence of inspection, palpation, percussion, and auscultation. Inspection. To determine if the neck swelling is in the thyroid gland, ask the patient to swallow and see if the swelling moves. This swelling moves and is consistent with a thyroid swelling. Inspection also focuses on whether the patient sits still and composed or is fidgety, anxious, and nervous. Note that this patient is fidgety and anxious. Comment on whether the patient is thin or fat. Patients with thyrotoxicosis have generalized weight loss and get muscle wasting, especially of the face, the hand, and the shoulders. Determine if the patient is underclothed and sweaty, as in thyrotoxicosis, or still cold when warmly dressed, as in hypothyroidism. The hands. The pulse is then examined. Tachycardia suggests thyrotoxicosis, and bradycardia mixed edema. Atrial fibrillation, recognized by an irregular pulse, may be seen in thyrotoxicosis. Determine if the palm is moist and sweaty. Determine if there is a tremor. Ask the patient to hold the hands outstretched in front of him, with elbows and wrists straight and fingers straight and separated. You may also place a thin sheet of paper on the hands. In thyrotoxicosis, there is a fine tremor. This is demonstrated in this patient. The eyes. 4 important changes occur in the eye. They may be unilateral or bilateral. These are lid retraction, exophthalmos, ophthalmoplegia, and chemosis. Lid retraction. This is caused by overactivity of the involuntary muscular portion of the levator palpebrae superioris muscle. In lid retraction, the upper eyelid is higher than normal and the lower lid is in its correct position. In demonstrating lid retraction, ask the patient to follow your fingers as you move it downwards. When the upper lid does not keep pace with the eyeball, lid lag is noted. This is not demonstrated in this patient. Exophthalmos. In this condition, the eyeball is pushed forwards by an increase in retroorbital fat, edema, and cellular infiltration. Therefore, the relationship of the eyelids to the iris changes, with the sclera becoming visible below the lower edge of the iris, the inferior limbus. The patient can look up without wrinkling his forehead. In severe cases, the patient may not be able to close the eyelids. This is clearly demonstrated in this patient. Ophthalmoplegia. Muscles may be weakened by severe exophthalmos, which is caused by cellular infiltration. The superior and lateral rectus and inferior oblique muscles are affected. Paralysis of these muscles prevents the patient from looking upwards and outwards. Ask the patient to follow the fingers as you demonstrate the actions of each of these muscles. This was not demonstrated in our patient. Chemosis. Chemosis is edema of the conjunctiva, caused by obstruction of the normal venous and lymphatic drainage of the conjunctiva. The normal conjunctiva, which is smooth and invisible, becomes thickened, crinkled, edematous, and slightly opaque. This is not seen in this patient. The neck. A neck or thyroid mass is like any other lump and must follow the same examination principles of a lump or bump. The patient is given a glass of water and asked to swallow to demonstrate the thyroid gland ascension with swallowing. This mass moves with swallowing. Invasive thyroid cancers may not move with swallowing if there is local fixation. Large goiters filling the entire neck may not move due to size. Ask the patient to protrude the tongue. If the lump moves as the tongue comes out, a thyroglossal cyst is suspected. The size, shape, symmetry, and surface of the thyroid swelling must also be assessed. Size, shape, symmetry. Simple goiters are usually symmetrical but may become irregular with time. The thyroid in Graves' disease is also symmetrical but irregular in a nodular toxic goiter. The skin. The skin overlying a thyroid cancer tends to be puckered when there is local infiltration. Palpation. Palpate the neck from the front to determine the position of the trachea. This is done by feeling with the tip of the 2 fingers at the suprasternal notch. The trachea should be central here. A thyroid mass may displace the trachea laterally. If a thyroid mass extends below the suprasternal notch and obscures the trachea, one must examine the thyroid cartilage. Most of the palpation of the thyroid is done from behind. However, it is from the front that we assess the size, the shape, surface, and sensitivity. This thyroid gland is enlarged bilaterally. It is large, symmetrical, soft, non-tender, with a smooth surface. From behind. Stand behind the patient and place the thumbs on the ligamentum nuchae and tilt the head slightly anteriorly to relax the neck muscles. Let the palmar surface of the fingers rest on each side of the neck on the lateral lobes of the thyroid gland. If there is still doubt about the origin of the lump, ask the patient to swallow while palpating. This lifts the lump that may be retrosternal to reach the examining fingertips. The consistency, texture, and smoothness of the gland are determined on palpation. Stony hard thyroid masses are usually malignant. Nodules, whether single or multiple, are also noted. Tenderness is assessed. If this is diffuse, thyroiditis is likely. Inferior extent of the thyroid and whether it is retrosternal or not. Can you get below this swelling? Thrill. Palpate for a thrill. Note that the normal thyroid gland is not palpable. Lymph nodes. Palpate for cervical and supraclavicular nodes which may be enlarged in thyroid malignancies. Percussion. Percussion is used to determine the lower extent of the thyroid that extends retrosternally. Percuss from in front of the patient over the sternum and upper chest wall. This thyroid is not retrosternal. Auscultation. Listen over the swelling for bruits. Vascular glands may have a systolic bruit. The examiner then thanks the patient for participating and allows him to get dressed. Thank you.